Okay, so you're here to learn about the new treatments, and that's what I'll focus on. And certainly I'll be happy to take questions about any of this stuff. I did bring Jacob in here too, because Jacob is our clinical pharmacist who works in our clinic at the university, and he is like the most important person on the team, I think. Well, the nurses.
I don't know about that.
Definitely, let's put it this way. I'm the least important person on the team. But Jacob is the one who checks to make sure that the new drugs don't interfere with other medications you're taking, and also has set up a nice system for trying to work with the insurers and the payers so that we try to get coverage done appropriately for the patients who need the treatment. Okay, so some of you may not be familiar with some of the terminology, so just definitions first. The goal of therapy is to clear the virus, and we call that sustained virologic response. This is clear now that sustained virologic response means cure. And it's defined by having no detectable virus in your blood at 12 weeks or more after the end of treatment. In fact, the data with these new drugs suggests that even if you're free 1 month after the end of treatment, that's what we call SVR4, that correlates very well with cure as well. So patients want to know very early, am I cured or not? So sometimes we will go with check the RDA at week 4 as well as week 12. Probably the 24-week check is no longer needed because the correlation between week 12 and week 24 is almost perfect, meaning that if you have undetectable virus by week 12 post-treatment, remember this is after treatment, so treatment stops 12 weeks later, you check, 3 months later you check, and there's no virus in the blood. In that situation, you're cured. And checking virus repeatedly thereafter is really unnecessary. There's virtually zero late relapse with this. Now, I have seen late relapse in the setting of cirrhosis, so my cirrhosis patients, I typically do recommend at least one check 1 year later. Okay, so the big paradigm shift now is interferon, which I guess to most patients and doctors and care providers is equivalent to poison now. But we moved from interferon-based treatment, which was typically the only treatment we had for hepatitis C in the past. Many of you may have had interferon in the past. We really didn't have any other options. It was interferon and ribavirin, and we did everything we could to get as much out of that medication as we could, because after all, there are 5 million people with this condition, and we had to treat people, right? Now, we have interferon-free treatments, improved efficacy, meaning improved cure rates, hardly any, nothing in medicine's zero, but limited toxicity. Patients who previously took interferon who now take the new drugs typically say, they say, did you give me the placebo or what? That kind of thing, because there's virtually so few side effects of the new therapy compared to what they took before. And the thing that we need our friends Jacob for, and people like Jacob, is to make sure that we check for drug-drug interactions and advise you on changing your medication before you go on therapy if needed. And some of the regimens you really don't need much change in the baseline drug therapy, and others you may. So there are 3 main targets of the virus for the new therapies. The hepatitis C virus, in order to recreate itself and replicate, has to go through this cycle of creating particle after particle after particle. How many viral particles does the average hep C patient make in 1 day? Who says 1,000? Who says 1 million? Who says 10 million? Who says 1 billion? Who says 1 trillion? There he is back there. He's right. 1 trillion copies a day. Yeah, that's a lot. Yeah, that's almost, what is it, about 1/5 of our national debt, right? So what is the national debt now? It must be over 5 trillion. Is it 5 trillion? I think it is. Yeah. Or more than that. We've lost count. Jacob used to be contributing to it, but now. Yeah, so. Anyway, so the 3 targets are these proteins that the virus makes and then uses inside your liver cell to make itself again and again and again, 1 trillion times a day. Amazing. So it's found a good way to survive, didn't it? So there's a lot of talk about Ebola, right? Just think of Ebola figured this out. So Ebola actually kills its host pretty fast. So that's why Ebola is nowhere near the threat that the media makes it out to be. But it's a deadly virus. You don't want to get it. Don't get me wrong. But this virus is a smarter virus than the Ebola. Anyway, so what I'd like to do now is just focus on some of the key. Everything I'm telling you today is interferon-free. Basically, in our clinic, when was the last time we wrote a prescription for interferon?
9 months ago.
9 months ago was the last interferon prescription in a university clinic that treats a lot of Hep C. So everything is moving towards interferon-free therapy. Now, if you happen to have genotype 2 and genotype 3, what we would typically give you is this combination. This is the only interferon-free combination for this genotype so far. Things will change over the next couple of years for this too, but sofosbuvir is SOF and ribavirin's RBV. Trade names, I don't typically give lectures with trade names, so you'll see my slides. These are all my slides. These aren't company slides, so I always give the drug names, not the trade names. So, but I think this sofosbuvir is Sovaldi, which is FDA approved. So, and we'll come to the ribavirin. Is it what's the name of that now? Ribapac or something? Yeah.
Well, there's a bunch of different ones, but it's
all ribavirin. Oh, okay, so here's the data for genotype 2. So if you don't have cirrhosis, never been treated, you take 12 weeks of the sofosbuvir is 1 pill a day, and ribavirin is twice a day, 95% cure rate. If you have cirrhosis but never been previously treated, it's about the same. Now that cirrhosis is compensated, meaning there's cirrhosis and there's cirrhosis, right? I told you about the liver before, so this would be someone who's got low MELD, no clinical complications, but has a biopsy or fibroscan or something showing cirrhosis. And you can be cured with cirrhosis, genotype 2, 94%. Now, if you've had prior treatment, the chance to be cured with just sofosbuvir ribavirin alone drops off as low as 60%. So we try to get 16 weeks if you're a treatment-experienced cirrhotic. And we've done that with some folks, but still there, it's not quite as good as in the other categories of the treatment-naive patient. Genotype 3, again, if you're treatment-naive, your chance for cure is extremely high, whether or not you have cirrhosis, 92 and 95%. And this is just with sofosbuvir ribavirin. However, if you have cirrhosis and have had prior therapy with PEG interferon ribavirin, your chance for a cure drops off to 60%. Even when you extend this treatment from 12 weeks all the way out to 24 weeks. So the regimen today for genotype 3 for all comers is 24 weeks as opposed to 12 weeks with genotype 2. And it works great in the treatment-naive patients, but these treatment-experienced cirrhotics are more resistant. And so there's been a lot of push for new regimens for genotype 3. One of the areas, so that's about, I think later on I'm going to tell you a little bit more about genotype 3 because some of you may have that. Genotype 3 seems to be the Achilles heel to the new therapies. Now most patients, what percentage of the Hep C patients in the United States are infected with genotype 1? 50%? Who votes for 50%? 60%? 70%? We're seeing some heads nod now. 80%? 90%? 100%. It's 80%. 80% today is the latest figure. Okay, so this is obviously where a lot of the attention is, and those of you who have Hep C in the room or have had Hep C in the room probably most likely were infected with genotype 1. It's the most common, 80% of the Hep C is genotype 1. Okay, so we've used this combination quite a bit, which is sofosbuvir and cimeprevir. And this combination is not FDA approved in combination, even though cimeprevir and sofosbuvir are both FDA approved. Nonetheless, the liver centers jumped on this regimen, and there have been lots of use of this. Here's the results of 12 weeks treating genotype 1 with this combination in non-cirrhotic null responders. These are people previously exposed to PEG-RIBA, failed PEG-RIBA, no cirrhosis, early fibrosis, 12 weeks of therapy, 93-96% cure rate. So we've used this quite a bit in clinic, and it even worked in cirrhosis null responders. What we found in our experience is that it does work in the compensated cirrhosis real well. And we're seeing experience in our own clinic with this, giving these kinds of results in the earlier stages of cirrhosis, maybe up to MELD 10. But when your MELD score gets higher, when you're sicker with cirrhosis, it doesn't seem to work as well. There's a drug called declatisvir. It probably also may get FDA approval this year. In Europe, this is one of the most common combinations for genotype 1 patients. It's not FDA approved again. This is not an FDA approved regimen. If declatisvir gets approved, though, this can be an option for treatment. And I was part of this study as well. It was published in the New England Journal this year. And you can see that the chance for cure for genotype 1 patients are the two bars on the left. So if they were treatment naive, 98% cure rate. If they had previous treatment with PEG interferon ribavirin plus either telaprevir or boceprevir, some of you may have heard those drugs, it was also 98% curative for that. So this was the first experience really published in retreatment of PEG interferon ribavirin, telaprevir or boceprevir failures. And 98% cure rate was pretty impressive, even though it was only 41 patients. So it got a New England Journal article because of that. Anyway, genotype 2, treatment naive. Genotype 3, treatment naive. Pretty high cure rates. But non-cirrhotic patients in this, no cirrhosis, okay? 2 weeks ago, the FDA approved Harvoni, which is a combination of these two drugs, sofosbuvir and ladipasvir. And sofosbuvir is that same polymerase inhibitor, and ladipasvir is an NS5A protein inhibitor. Declatisvir is an NS5A protein inhibitor. So if you look at that combo there, sofosbuvir, declatisvir, and this combo, notice anything similar? They're like the same, right? Except different names, but they're different molecules. So it's interesting when you look at the data for this combination, it comes out pretty close to what you see with sofosbuvir, declatisvir, but the sofosbuvir, declatisvir was a non-registration trial and a small number of patients. This is a registration trial with large numbers of patients. And this is where the excitement starts to really resonate. ION 1. Okay, so again, there's going to be like 3 studies in a row I'm going to show you. They're all sofosbuvir, ladipasvir, Harvoni. And in some cases it's with ribavirin, some cases without ribavirin. And in some cases there'll be a difference in treatment duration. So if you look at the ION 1 study, these were patients with genotype 1. By the way, Harvoni and the AbbVie 3D, 3-drug regimen, and BMS's 3-drug regimen at this point in time in the United States are only approved or being evaluated for approval, depending on the treatment, for genotype 1. So this regimen is only for genotype 1. Okay, so ION 1, these are patients never previously treated. There was a reasonable representation of patients with cirrhosis. And what do you learn from this slide? Well, you don't need ribavirin, and you don't need to treat for 24 weeks. So 12 weeks is sufficient, and you don't need ribavirin. ION 2, now we get to the patient who previously got treated with either peg interferon ribavirin or peg interferon ribavirin with either telaprevir or boceprevir. And a reasonable percentage of cirrhosis, about 20%. What do you learn from this slide? Ribavirin not necessary again, and question on 24, huh? Who might need 24? Who needs 24? Yeah. So if you have cirrhosis and are treatment experienced, you might need 24 weeks. And that's the recommendation. If you got treated previously with peg interferon ribavirin or peg interferon ribavirin with either telaprevir or boceprevir, and your doctor is talking to you about Harvoni treatment, and you have cirrhosis, remember, cirrhosis, treatment experienced, you're likely going to get a prescription for 24 weeks. How much does 12 weeks cost? $95,000. Okay. All right. ION 3, what did they do here? No cirrhosis, treatment naive, genotype 1. Ribavirin not needed. And look at the bottom, 8 weeks. I heard a wow up here. We've got some wowing going. Yeah. So 8 weeks in a treatment naive, non-cirrhotic. Now, you look at this and you say, ooh, that's not as good as 99%. Right? Pretty good. So the thing is, they looked at this data and they said, oh, the relapse rate at the 8 weeks was a little higher, significantly higher, but it still was pretty low. And there's a proviso to this recommendation on 8 weeks, and that typically 8 weeks would be reserved for a patient, if you're going to use it, it would be for a patient who has no cirrhosis, treatment naive, and their baseline viral load is less than 6 million. Okay, so that's one approach. And you know, when you're facing obstacles in decision making and you're trying to come up with additional treatments and so on and so forth, you look for other options, other treatment regimens for some of the to solve some of the problems. So one of them is on that genotype 3 to get a better, more potent NS5A inhibitor. And that's shown here. 5816 is an NS5A protein inhibitor. Now remember, if we look at the backbone therapy, right? So you've got the soft 5816, soft DAC, soft ladipasvir. All those are showing kind of similar results. And this is a phase 2 study I presented at EASL this year. And this goes across all genotypes. So it looks pretty impressive. It's in phase 3 studies now. It's not FDA approved yet.